Hey everyone, this is Victor from Cyborg for Life, and today I have a very special interview for you. He's a world-class orthopedic physical therapist who specializes in the post-op rehab for both limb lengthening and deformity-corrected patients. Please enjoy the interview with Moshe Roth. All right everyone, today we have a very special guest joining us. He's a world-class physical therapist specializing in post-op rehab for limb lengthening and deformity-corrected patients. Residing in Baltimore, Maryland with his wife and 5 children, he runs a private practice with a unique concierge service which allows him to conveniently meet his mobility restricted patients at their residence to expedite their recovery and get them back to doing what they love. Please join me in welcoming world-renowned orthopedic physical therapist, Moshe Roth. Hey Moshe, how are you doing today?
I'm doing great. Thank you, Victor. Thank you so much for having me on today. Very humbling given the lineup of guests that you've had on prior. So here it goes.
Please don't be modest, man. You've worked with some of the limb lengthening greats, which we're going to talk about in a second. But as I get more invested in this industry, amazing talent like yourself is a true honor to come across, because you're literally one of the best in the world when it comes to limb lengthening rehab. So I want to talk about some of your qualifications before we start. You earned your master's in physical therapy and public health degrees from Long Island University, New York. After working in the New York City school system for 3 years, you transferred to the Rubin Institute for Advanced Orthopedics at Sinai Hospital in Baltimore, where you worked for 8 years under limb lengthening greats Dr. Paley and Dr. Herzenberg, as well as Anil Bhave, who is the original limb lengthening physical therapy and rehab director who's impacted the limb lengthening industry in terms of physical therapy as we know it. So you've also treated hundreds of patients over the past 20 years in a variety of settings, including limb lengthening, deformity rehab, aquatic hydrotherapy, sports athlete rehab, and pediatric orthopedics. In 2012, you were invited to Israel to educate therapists on how to properly set up their rehab for limb lengthening and deformity-corrected patients with their fixators. And even nowadays, you're branching off and you're doing things like helping lengthening clinics set up their post-op rehab centers. So, Moshe, what an amazing list of accomplishments. But I want to ask you, I'm going to go way back. You've been your physical therapist for 20 years. So I want to ask you, what do you enjoy most about your job?
That's a tough question. But I honestly, I tell a lot of my students, I certainly tell my kids here at home that I've had a great career. The past 20 years have been really very rewarding, very fulfilling. I tell my kids every day that, I wake up every morning excited to go to work, and they should do the same when they're looking for, what kind of profession they want to be in. But, it's really a blessing to be able to wake up every morning, enjoy what you do, enjoy the people you work with. I think that's really the crux of it. The physical therapy profession is a little bit different than most professions, because I see, a physician sees their clients, once a month, maybe once prior, for a pre-op. Physical therapy, I'm seeing my patients, my clients twice a week, maybe 3 times a week. And you really form great relationships with the clients, with the families, especially doing, the rehab at home. You get to see their real environment. You get to see who they live with, how they live, where they live. It's real. And that's, I think, what I love about my job is just the relationships that I make with my patients, with my clients, with their families. Sometimes it's even, long term, especially with the limb deformity children that I see. I'll see them when they're 2 years old, when they're 4 years old, when they're 6, 8, 10, and you really get to see like the whole progression of how they're growing up. Even with the adults, just having those relationships, that are long term and long lasting. It's very, very rewarding. Like I say, I love my job. I love what I do. I love the people I meet. It's just a great profession, a great job.
That is amazing to hear. A job that has passion behind it at the core is one that is truly fulfilling. So now you were based at Sinai's Rubin Institute for Advanced Orthopedics for 8 years. Can you explain what your time like was when you were there? Because I know when I was doing my rehab there for both of my broken legs, it was completely amazing, an amazing experience for me. But I want to ask, your perspective as a physical therapist. What was it like at Sinai?
Sure. So going back a little bit back in history. So like you had mentioned in the intro, I graduated just about a little over 20 years ago from PT school. My first job was in New York City for the Board of Education. I always wanted to do pediatrics. That was always my dream. So when anything ortho came up in school, I tuned out. I just wanted to do pediatrics, wanted to work with kids. I had this dream of, working in Africa and healing everybody, and, just the downtrodden, the poor. That was really where my altruistic side, came in. So my first job, like I said, like you had mentioned, was with the Board of Education, and I was looking for a pediatric job, and I happened to fall into this place not too far from where I live at Sinai Hospital. It was really life-changing. It had all of the aspects that I had set out to do professionally. The team that was there, as you had mentioned, Dr. Paley, Dr. Herzenberg had started this program. Anil Bhave was running it from the rehab end. The team that was set up in terms of therapists, everyone is a gem. I still am very, very close with those therapists. And like you said, it was such an amazing place to work. The families that came through were really looking for a lot of hope. To have a child that's, born with some kind of deformity, they don't know what to do, don't know where to go. And then, they land here in Baltimore and the doctors give them an option that they had never really had before. They go through the limb deformity procedure, the surgery, which is very involved. And then you go through the rehab, which is, takes months. And like I said about the relationships, many of the families that I was involved with, we became very, very close. And it was just a whole, the families were involved, that we had the camaraderie, the mentorships. I don't want to forget about the mentorships. I'm still in touch with Dr. Herzenberg to this day. We're good friends. I view him as my mentor, until this day. Anil, he was wonderful. Taught me a ton, taught me so much, to the extent that I was able to get this love of orthopedics, where I was seeking out pediatrics, I have this love now of orthopedics. And just combining the two was also like so rewarding, so fulfilling. And I have to say a thank you to Sinai. The highlight of my career was in 2010. We staffed a hospital in Haiti in June of 2010 after the devastating earthquake in January of that year. Dr. Herzenberg, and along with his wife, who was a nurse, put together a team of about 22, 24 people from Sinai. We went to a hospital down there, and it was just helping people, healing people. And I to this day, I credit Sinai for giving me that opportunity. It really changed my perspective on health, on healing, on medicine.
You've seen a lot of complex deformities when you went over to Haiti and whatnot, but you were also invited to Israel to help set up their clinics, for physical therapy rehab after limb lengthening and using external fixators. Can you explain what your experience was like with that?
Sure. So it's sort of an extension of my experience at Sinai. As many of the listeners might know, the doctors at Sinai run a international forum, an international class for limb length deformity correction. I believe it's at the end of August, the beginning of September. So in 2011, along with Anil, many of the therapists gave our own little course on limb deformity correction rehabilitation. My part that I gave over was on aquatic therapy, aquatic rehab. And the hospital in Israel called Alin Pediatric Rehab Hospital. It's the only rehab hospital in the entire country. So basically, any child who has anything complex going on goes to Alin. Post-surgery, they have a number of clinics that are set up for consultations. So Alin is really the place to go for pediatrics. And they also have a world-class aquatic program. They have an Olympic-sized indoor pool where almost every child, barring any complication, goes in the pool. So because I did the portion on aquatic therapy, they reached out to me soon after about how to put what to do with with children with fixators in the pool, and what kind of exercises, how does the pool help? And, my wife and I, thought about it. We picked up the family and we moved there for a year. And it was tremendous. It will come to the limb deformity course, Dr. Bohr, Dr. Adel. So just having that collaboration with them on that side of the world was rewarding. And yeah, we saw a lot of different things. They definitely have a different treatment approach. Many of the therapists there, who are also wonderful therapists, some were trained in England, in Australia, in Europe. So it was interesting to get a different perspective of, even within physical therapy, just to get a different perspective of treatment philosophy, of, again, the collaboration, the learning opportunities that were there. I highly recommend anybody in healthcare or medicine, if they have an opportunity to go to a different country, just to see different things, it's completely rewarding, but also a little bit, it changes your perspective on a lot of different things. How to treat people, definitely different cultures that that they have to adapt to, different language. It's funny. My first day there, the head of therapy, the head of the department, she said, "We all speak English here, but because we want you to learn, we're all going to speak to you in Hebrew." and I broke my teeth, but it was phenomenal because you get to interact with the patients much better. You get to really learn what they're going through. You get to interact on their level. And it was just it was phenomenal. Even Paley does some surgeries in Israel, so I got to see some of his patients. I vaguely remember there were maybe 2 or 3 that had surgery in Florida, came back home to Israel for rehab, and I was able to collaborate with Dr. Paley on some patients while we were in Israel. So it was just also, if Haiti wasn't the highlight of my career, definitely working in Israel, and also being bringing my expertise to the table, and having people giving over. I love teaching. Whenever I would have a student, I loved it because I just love giving over and giving over my experiences and really trying to train the next generation of physical therapists. So it was a great opportunity to teach, but I also learned a tremendous amount. So
absolutely, and that's exactly why I wanted to really dive into your background, to really highlight your experience, because I don't think a lot of people realize, when you can treat patients with these type of complex deformities in underdeveloped countries and whatnot, you see everything. I mean, you work with patients from all walks of life now, but to go from there, you truly do have a deep depth of experience. So I want to kind of ask some basic questions that patients always kind of throw at me, and you being an expert world-class physical therapist, I want to throw them at you. So,
go for it.
So the first one that I have here is a patient, always asks, what muscles should a patient who underwent femur lengthening, whether it be from an external fixator or an internal lengthening nail, be focused on most? What muscles tend to get the tightest?
That's a great question. So with the femurs, there are just that many more what we call two joint muscles that cross over the two joints, the hips and the knees, the pelvis and the hips and the femurs. So the hardest muscles or the most important ones to stretch are definitely the quads, the hamstrings, the hip flexors. A lot don't think about the hip rotator muscles, but even getting some flexibility in the hip for hip rotation, very, very important. But more often than not, especially with the internal lengthening, the hamstrings are getting tighter. External fixators, the quads get a little bit tighter, but what I'm finding with the internal nails, the hamstrings are getting a bit tighter. Definitely the IT band, a little muscle, but really gets affected with limb lengthening. A little hard to stretch, a little complicated, but it's also, we have to stretch those out as well. But it's really just hamstrings, quads. People don't think about the gastrocnemius down in the calf, also an important muscle because it does work as a little bit of a knee flexor. So we got our abductors. We don't want any scissoring of the legs coming in. So those groin muscles, very important. So I would say, but hamstrings are pretty much the first to start getting really tight.
Yeah.
Generally.
Yeah, I always kind of realize that from a lot of patients that reach out to me. They tend to say that their hamstrings and their posterior chain gets really tight. But then everything else, that you mentioned is true. So what about for the tibia? Because a lot of patients think that it's just the calf, but what about the tibialis anterior? Do those get tight as well? And can you explain some muscles for the tibia lengthening?
Yeah, so a lot don't think about the tibialis anterior. We're so focused on preventing tiptoeing, or plantar flexion with the toes pointing down, and that's definitely the gastroc, the soleus. So those are important to stretch. Definitely our number one concern. But even the tibialis anterior, because in general the whole ankle joint gets tight. So if it's not pointing down, well, it's not coming up either. So stretching in all directions, and even inversion, eversion and inversion, going side to side with longer lengthenings. The heel starts turning in a little supination. So then when they're ready to walk, they're almost walking on the outside of their foot. And that's not because of strength. It's more because of just of how the muscles are getting really tight and pulling that heel and pulling it more inward. So it's coming into a supinated position. So working on inversion, eversion. Many therapists, when they stretch, if they use my hand as an example, they're stretching from the midfoot or the toes, but it's really, you got to get the heel, because so many of those muscles focus right on that heel. So if we just stretch, we're really just causing, we're bending the toes back. We're not really doing much for the actual ankle to come back. So, really getting that heel to stretch is very important.
Now, how does a patient's plan of care differ if they have an internal device versus an external fixator, let's say on the tibias? Surely there's, limitations on their movements because, an external device is more bulky. But what is your workarounds for working with a patient who has an external fixator versus an internal lengthening nail?
A benefit of the external fixator, there's also less invasive. It's just the pins going through the bone rather than putting that internal rod into the bone and sitting there for about a year or so. So the external fixator is a good option for weight bearing and less invasive. But cosmetically, the internal ones are definitely the way to go. A lot cleaner, less invasive surgery that they have to worry about. So the internal ones are definitely the way to go. What I'm seeing is that the internal ones, because they're less invasive than the external fixators, there is some more flexibility, or I'd say some more lag time in terms of the flexibility of the muscles. So what I try to do with in general femurs and tibias is just to try to make put up enough collateral in the bank, so that when things start getting tight, we've worked those muscles so intensely in the beginning of therapy. We've gotten so much movement and flexibility, like I said, in the beginning, that we have some lag time as the lengthening starts, continues, that we're able to, push off that tightness, at least for a few centimeters if we can. Work enough collateral, like I said, in the bank, and get enough flexibility in the knees and the hips and the ankles, that we could just push off that tightness for as long as we can. So a lot of strengthening, a lot of flexibility in the beginning, more intense stretching, maybe less strengthening in the middle, and then full-blown stretching as we get to the end.
What can impact a patient's walking gait? Because a lot of patients are really worried about, when can I start walking normally again, so people won't notice. You mentioned earlier, obviously, all the muscles that can, get tight, but are there like a few muscles in particular that really need to be kind of strengthened after lengthening because, atrophy takes place? What's your perspective on that?
Two factors that are affecting the strength aspect. One, even with the stride nail, let's say, patients aren't walking around all day like they would, before surgery. There's a lot of pain. There's a lot of discomfort involved. So they're doing a lot more sitting than than they're used to. Even if they're getting 3,000-4,000 steps a day with the stride, for sure with the precise, they're not walking at all. So those muscles do atrophy, especially the glutes, especially like you were talking about the posterior chain, the hamstrings, the gastroc, just because they're not being used. And they're actually being, for more, all intents and purposes, they're being sat on the entire day. But then you add on that we're adding all of this length to the muscle. And the muscles, they're used to being worked, and in a functional way, not just, doing open chain exercises is important, doing kicks, straight leg raises, long arc quads, ankle pumps, all those are great. But until they actually have to put into functional use, like walking, they just need time to adapt. Getting them stronger in general is an important part. And in terms of walking, with the tightness that's involved, with just the mechanics that might be altered, like I was talking about with the ankle, so if that heel is rolled a little bit, or if the knees are tight, your body is always programmed to want to get moving. How it gets moving is a different question, and what that movement looks like is definitely different. But more weight bearing will just be stronger muscles, and then just working on the gait. Pools are great. Pools and bikes are the number one and number two. If in the beginning of rehab, just using an exercise bike just to get that flexibility and that patterning. The more steps we take, the more flexibility we have in a functional way. We'll just get people back to walking that much quicker. And access to a pool, just to work on that gait pattern if they can, during the rehab, during the consolidation phase is beneficial.
That's a great way to answer it. And I think that you're 100% on point, because I noticed that a lot of patients, they said that when they did things like the stationary bike, or, they started to get in the pool, their muscles had a more natural, movement to them, and they were able to regain their walk a lot sooner. Great answer. Now, Moshe, I have another question, and it's, what if a patient develops a muscle contracture that prevents normal knee flexion? What are their options? Do you typically just kind of, start with aggressive physical therapy and stretching, or do you even use assisted tools like A-stem?
So my number one is to avoid the contracture.
Okay.
That's how we deal with a contracture. We avoid it.
Okay.
But it definitely does happen. But A-stem, I was trained in A-stem. I don't do exactly A-stem, but we do a different kind of, I call it orthopedic massage, which is also, pretty intensive, and just breaking up all that scar tissue, and just stretch, really intensive stretching. I often tell patients that if they're going to outpatient therapy, you want that therapist to have their hands on them all the time. Like, we want just keep working, like keep stretching in all different positions, sitting on their bellies, lying down, just any way that we can get just get some flexibility into that knee, and just continue to go with it. Keep going. Anything in, everything, strapping patients down, just stretch. That's the way to do it. But we also have to break up that scar tissue. We have to get those muscles flexible. So, heat is very good to that, using some of those home massage remedies. Those are good. But just stretch. But number one, avoid the contracture.
Do you also recommend that they do stretching at home on top of their physical therapy sessions? Because a lot of patients think, oh, I can go to therapy for 45 minutes or an hour a day, and I'm done for the day. What's your suggestions on that?
You've got to put in the time. I could do an hour of therapy. I could even do 2 hours if you want, but you just got to keep on stretching. And the reality is that it's really not that expensive. You get one of those hamstring stretching bands, with the little loops on it. That goes a long way to self-stretching. A lot of positioning, so being on your stomach for a part of the day, sitting in a chair part of the day, putting weights on your ankles, either in sitting or on your stomach, to just increase the stretching. that goes a long way. Self-stretching, having somebody give you a little push every now and then, just got to keep those muscles flexible. And especially because more often than not, they're lengthening throughout the day. So, if they wake up in the morning, they do some stretching, but then they're lengthening a millimeter a day. They're not able to, that lengthening is going to it's going to take its toll throughout the day. So really, as much stretching as we can do. I know it's hard. Some people are doing lengthening on their own. Some, if there are parents involved, if there's a spouse, they don't always make the best therapists, but it's just somebody there to, just give that joint a little bit more flexibility. I always tell my patients, the mind will never let you hurt it. Will never let the body hurt itself. So, they give a little stretch and then they say, oh, okay, that's right there. That's good. But then somebody else will come in and be like, nah, we can do a little bit, go a little further. But, even if we get right up to that point of where the patient is comfortable, it's still something. It's still, getting those muscles, flexible, a little bit, stretching throughout the day is much better than 1 hour of, intensive stretching and then doing nothing.
Right. Yeah, that's exactly what I always tell my patients that contact me. I say, hey, look, you can go to physical therapy, but you have to do hours after that to get the best result possible. Now, Moshe, if a patient gets lengthening on the femurs, or even the tibias, a major worry is that they're going to lose explosive power for if they play sports or if they're just, active, in terms of fitness. What is your treatment philosophy for a patient who's looking to get back to doing what they love, let's say for running?
So you got to walk before you run. That's the most important. So really, and I get this a lot because patients are very much focused on that. They've invested a lot in this surgery, and they want to make sure that they're going to come out, looking, as good, if not better, than when they went in. But a lot goes on in the meantime, in the interim. So you got to walk. You got to get those mechanics down. You can't just, hit the ground running. You got to get the mechanics down. You have to get the technique going, and you have to get all the joints moving around. And in terms of the explosiveness, so that comes from the upper legs, from the hips, from the thighs, from the glutes. But really, the feet are really important as well. There are so many facets to walking and running that the foot has to do. And more often than not, it's a stiff foot. It's a weak foot. It's a foot that hasn't touched the ground in, a good couple of months. So really getting those feet honed and trained for running is just as important as, just strength building for the upper legs. The foot is the first part in the chain to get your foot off, the ground, but it's also the last that absorbs all of that force coming down. So, let's say we get all this strength in our glutes and thighs, and we jump up. Well, we got to land on something, So just getting those feet primed for running as well is very, very important. But like I said, biking is great. Resistance biking, doing the leg press. Also as the doctor allows with weight bearing restrictions. But as much as you're able to do, just, continuous repetitions. There are different, weightlifting philosophies out there. I like more reps and lower weight, actually. So just getting like we said before, because those muscles are so long now, just training them, with continuous repetitions, continuous reps, just continuous use is so important. And then, once you get comfortable, once you get fluid, then we can start adding more power and more resistance and more weight to those new muscles. So that's pretty much how, my philosophy on that.
I love that. And that's actually kind of what I did after my LinkedIn. I kind of did the reps and then I slowly, gradually added the weight and everything kind of returned. I love that. And I think a patient is going to love your angle on that as well.
Yeah. Now, and I love to, if I could just add, because, one thing that's interesting, and I would love feedback from the patients. But for example, like let's say we add, you go for the maximum, tibias, femurs, and you're 6 inches taller now, So let's say you want to dribble a basketball, right? So that muscle memory of your hand dribbling a basketball, well, now it's got to dribble a basketball 6 inches tall.
Yeah.
Or let's say you're a pitcher. So now you're pitching from a mound. And, your perspective was one area when you were throwing a ball. And now your perspective is that much higher. You're swinging a bat, swinging a tennis racket. Just because we've added so much height, all those proprioceptors of the feet, of the mind, of the eyes, that whole perspective on how you're viewing the court has been changed. So, there's so much, not just running in power and agility, but it's all those fine motor things that also go along with sport, catching a ball, the angle of balls now that are cut, so that perspective of training is also important, not just the strength and the weight, but it's the fine motor things that we have to do also.
They have a monolateral external fixator. How do you approach that for physical therapy, rehab, and stretching?
So like I mentioned before, the external fixator does have its complications. Usually the way the placement of the fixator, it's right on the side of the femur there. So it's pretty much going straight through the IT band. More often than not, the IT band is tight to begin with. Just that's our, natural, our natural setting of that, having, tight IT bands, tight hamstrings, as we all do. So then putting some, nails through that IT band is not very exciting for that IT band, which then does affect the goes all the way down past the knee. So it does affect the knee flexors and even the knee extension. The IT band is both a knee flexor and an extensor, so it can affect both of those motions. Massage is very important to that area. Sometimes even kinesio tape to that area is pretty good, just to make it a little more comfortable. Stretching. That's because now you don't just have a tight muscle, but you have nails going through those muscles. So it's a trauma on top of a trauma. So a little bit different, just something to that we have to be aware of, that we have to keep our eye out for.
Gotcha. Now, Moshe, when you are working with a patient who's achieved full bone consolidation, you mentioned earlier they need to walk before they run and run before they sprint, but what's the typical timeline, or I would say the average timeline, that you see a patient ability to run or sprint or jump or play, non-professional level sports again, like basketball, tennis, or martial arts? Is it like, 6 months after surgery? Like, what's your typical time frame that you see your patients recover and get back to doing those things?
Yeah, so also depending on the level, depending on how amateur we are, it could be it could be anywhere from about almost 10 to 12 months. Honestly, it's from start of surgery. So let's say it's three months of surgery, of the lengthening, and then ideally another 3 months of just consolidation. So that's already 6 months out, and then just building up that strength, building up that agility. And then fine tuning everything. It might be, it could be, from like 8, 10, 12 months out, till the patient is feeling, that I've got this. Often I tell the story. I had a patient once, not a limb lengthening, but a different orthopedic surgery, and she told me 8 months out, she said, what happened today? I didn't think about my knee. And I said, what are you talking about? She goes, every morning I say, how's my knee? And I go about my day. I said, today I didn't think about my knee. So, when a patient will start running, that might be, 8 months out. Are they still going to think about their limb lengthening and all the repercussions? They're going to think about it. So it might be a year until they, get out on the court and let it fly.
Now, Moshe, I want to transition now, because ever since you started your own physical therapy practice, you've successfully offered something called Concierge Physical Therapy, which is a service where you actually meet your patients at their residence, which is really unique, and it's very convenient, for them, so that they don't have to, get in their car and transit to the physical therapy center and, all that nonsense that goes in between. Not that it's bad, but, can you explain the reasons of why having something like a concierge service is so beneficial to the patients in the local area?
Sure. So as part of one of the jobs that I've had over my career, I was a home care therapist, where I would see patients in their homes, mostly elderly. But what I loved about it is that it was real. I saw the patient in their home. So instead of practicing on the finely cut and measured stairs in the clinic, I'd go to their home, and their stairs would be much taller. Or they'd have a spiral staircase, or they'd have missing stairs or no railings. So it was much more real. The doorways, how they get on and off the toilet, what their setup is at home, who's home with them, how they get in and out of the door. All these things are so important. And at a clinic, we work on certain things, but at home, it just makes it more real. And you're able to intervene. You're able to problem solve with the patient, wherever they might be, and be able to help them that way. And aside from, like you were saying, especially after limb lengthening, if somebody's doing this on their own, it's that much harder to get to the clinic, 3 times a week, every day if needed. So I just meet them where they are. A lot of my clients are working during the day, so they want to be seen after hours. I'll accommodate that to a certain degree. I do have to be home, before 10 curfew, but I definitely, accommodate patients' schedules, definitely work-wise. But it's also like you were saying, getting out of bed, into the wheelchair, out of the house, into the car, then to the clinic, having their hour or so therapy session, and then getting back in the car, back into the house. That could be a 3-hour ordeal. Which, like you said, if it could be done, it's great, but that's a lot of time, either for a caregiver or a spouse to take off, and especially if somebody's working during the day, that's a lot of time involved. So I could, what I've found is that a lot of patients find it very beneficial to cut out that lag time. I'll meet them at their house. We'll set up the, however we need to set it up to make it as efficient as possible, and we'll get the rehab done at home. I'll bring everything that we need, to probably, more often than not, bring to the house. But we can make it work and, definitely accommodate as needed.
See, I think that was one of the coolest services that you offer, because I remember exactly that 3-hour ordeal that you're talking about. When I was going through my lengthening, I was like, oh my gosh, from leaving at 10 in the morning to coming back around 1 lunchtime, I was like, wow, there's 3 hours, and then I got to do my lengthening and stretching, and so that's a huge.
And it's exhausting.
It is exhausting, just to, think you have to, and then you have to crutch your way. Oh my gosh, it's crazy. So I think that's going to be a really powerful service that you offer in the local area. Now, I also know that, there's patients who are done lengthening, and who get lengthening done, and they may not be here in Baltimore. Now, recently you've been mentioning that you've added a new service branch to your practice, virtual physical therapy. Due to the whole COVID pandemic, a lot of people, it was really hard for them to go to physical therapy regularly. So, and this can go international, because now, remotely patients can get past some muscle tightness or other conditions that they can't afford surgery for. So, can you explain a little bit about what you can do in a virtual consultation with a patient who may have the beginning symptoms of a muscle contracture, or just need some extra guidance from an expert physical therapist like you, who can give them instructional physical therapy stretches and exercises that they can do at home?
Sure. So like you mentioned, one of the silver linings of the COVID pandemic is the explosion of telehealth services. For many things it works. For certain things, I don't think it works too well. And I've worked out physical therapy for telehealth for certain conditions. Ideally, having somebody there with the patient to stretch is imperative. But what I've done is, via the video, being able to guide the patient or the caregiver how to stretch, how to position, where to put their hands, how high, how far, all of these things, which are so important. And even, if a patient, like I mentioned before, that hamstring stretcher band, we could use that for a good number of stretches, for self-stretching. And then, with angles of the camera, we could monitor how the patient is progressing, it's always better to have hands-on therapy, but, we could do a lot via teletherapy as well. As long as there's somebody there willing to help out, or even if the patient's on their own, we could make it work. It's a little scary doing telehealth PT. Not a lot of PTs, when I speak to people about it, they think it's crazy. But it's worked, for a number of diagnoses and patient populations. It's actually it could actually be beneficial. A lot of rural folks, who don't have access to physical therapy, it's better than not getting anything, or it's better to have a trained physical therapist, with the certain conditions, keeping an eye on them, rather than somebody who doesn't know what they're doing, or even not having anybody check on them. So
yeah, I think that's going to be a huge service, and I'm going to recommend that to a lot of patients who reach out to me, because I get it all the time, and I'm like, well, what's your physical therapist say? I don't have one, or they don't know, they're just an ATI or whatever. They need an expert like you. So, and the third service that you're offering, which is really, really cool, I think this is going to be huge as limb lengthening, becomes more popularized, is a setup service for lengthening clinics, where you can actually help a lengthening surgeon set up their physical therapy rehab center. So why is it important that a limb lengthening surgeon have a rehab center that caters to these patients who are undergoing this lengthening process, and not just send them off to the, your typical physical therapist down the street?
Yeah, so we would often have that dilemma when we were working at Sinai, is passing off the care to another therapist. More often than not, they were one of two things. Either they were a sports therapist or they were a pediatric therapist. But rarely did we have anybody who knew what to do with a fixator, or what to do with limb lengthening. And we did a lot of training, a lot of education, a lot of videos, a lot of pictures that we would send with the patient. Because again, it's, there's so many potential pitfalls during limb lengthening that could happen. Having a trained physical therapist, somebody who can anticipate what's gonna happen, who can anticipate the problems, beforehand. Like I said, avoid the contraction, but that goes with every muscle. Just trying to avoid the pitfalls is imperative to a successful lengthening. And the process really starts from day one. How to get out of bed, how to move, how to use a walker, how to adjust to getting on and off the toilet. All these things are so important, and it happens from day one. So having a trained physical therapist who are comfortable with the procedures that this patient just went through, who can answer many of their questions on a practical, functional level. The doctor is knowledgeable, but they're not gonna more often than not, they're not going to answer all the questions about function and mobility and movement. Nurses will take care of, the surgical, procedures and the surgical sites, but really the physical therapist from day one puts that patient at ease. How am I going to get out of this bed? How am I getting in and out of the toilet, the shower, on and off the toilet? All these things which are so, so important and so crucial to just everyday life now that they're going through this procedure. And then, like I said, what to do in the beginning of the process, what to do in the middle of the process, what happens at the end of the process when things are all, hitting the fan, and everything is tight. And, the patient's having this symptom and that symptom. And, am I ever going to get better? All these things which are, doctors can answer, nurses can answer, but really having a physical therapist who's trained to really, deal with on an experiential level with these patients day after day, and be there with them on their journey, because that as physical therapists, we're really with them. Like I said in the beginning, 3 times a week, 5 times a week. I often give my patients know they can text me, every day, any time of the day, hey, Moshe, I woke up and, my leg is falling asleep. What should I do? So, just telling them different positions, different things, and obviously being in, having that communication and that relationship with a doctor, where, not only is it, having, the doctor's, cell phone number, but having the doctor trust the therapist, that, having that honest rapport with the therapist, trusting what we're telling them, and really taking our lead, because we're the ones that are seeing this patient, every day, and being able to monitor. Oh yeah, she was, they were complaining about pain, on Sunday, and then Monday, and now it's Wednesday, so it's not just a, one-time shot. They're having pain, but it's been lasting for, a couple of days. What should we do? So it's really having that teamwork with the doctor. That's really important, and having that therapist sort of in their back pocket. that they could, that they have that trust and that they have that relationship with, that they know, oh, I've got an emergency patient coming, can we fit him in? Can we fit him in for an hour every day? Not a regular clinic where they're not really set up for seeing patients every day for an hour, So just having that, like I said, having that teamwork, that collaboration, I think is imperative. And, that's what worked at Sinai. That's what makes Sinai unique, is that, there was that relationship, there was that camaraderie, there was a trust level between, the therapists themselves, but also with the doctors and the surgeons, the physicians, nurses. That whole team approach was phenomenal and very important. I think any clinic should really, have that same approach.
Yeah, I completely agree. And I know there are lengthening clinics that need you to help them. Moshe, for patients who are local in Baltimore and want to either consult or hire you for your concierge therapy service, or a lengthening clinic that needs help setting up their rehab center, what's the best way that they can reach out to you?
So the best way is probably through email, which is mosherothpt@gmail.com.
Awesome. And I'll be sure to post that in the show notes so everybody can get a hold of you. Moshe, as a physical therapist with exceptional skill and passion to help his patients recover and get back to doing what they love, what are some last words of advice that you can instill on lengthening patients who, either are just doing typical cosmetic lengthening or had it for a deformity or a leg length discrepancy?
That's a great question. What's there's so much to advise. Avoid the contracture. That's the number one. Stretch every day, all day. That's number two. No, but really, in all honesty, you got to take it one day at a time. It's a long process. You've invested a lot in this, both financially, psychologically, emotionally. There's a huge investment in this process, in this journey. And I would just say, take it one day at a time. It's a marathon, not a sprint. But things are going to change every day. I tell my patient, you are going to be so in tune with your body by the end of this. You're going to know every part of your leg by the time this is over. This toe is hurting, and this part of my ankle is hurting, and how come my upper lateral kneecap is hurting? And that's the reality. Things are going to hurt, but then the next day things might not hurt. Different things are going to hurt, but then they're going to get better. So it's one day at a time. If things start getting tight, it's not the end. There are many options that we can do to alleviate many of the complications. But the reality is that there are complications. Muscles do get tight. Walking doesn't look as good as it does at the end as it did before you went in for surgery. But take it one day at a time. Focus on that day. Focus on what I can do to make myself better today in order that tomorrow can be that much better. I
love it. Awesome way to end it. All right, everyone, that is Moshe Roth, elite lengthening and rehab therapist in Baltimore, Maryland. Moshe, thank you so much for your time.
Victor, thank you so much for having me, and continue doing what you do for our community.
Absolutely, I will do. Well, there you have it from the rehab expert himself. Moshe is an extremely passionate and knowledgeable physical therapist with over 20 years of experience who helps his patients avoid complications and achieve a pain-free outcome so that they can get back to doing what they love in a timely manner. Not only that, but Moshe is also on a mission to help improve the convenience of limb lengthening rehab by his 3 unique services of his practice. And they are his Concierge service, which allows him to meet his mobility restricted patients at their residence, his virtual consultation and telehealth service, which allows him to connect with patients who are, lengthening remotely or across seas, and his limb lengthening clinic setup rehab service, which allows him to talk to limb lengthening surgeons who have a clinic that need help improving their physical therapy and rehab center so that their patients can also achieve a successful outcome. If you're interested in reaching out to Moshe for either a consultation or help setting up your lengthening rehab center, you can find all his contact information in the show notes. Until next time, this is Victor from Cyborg for Life, signing out.